of 55. Now look at the HCO3. It's 34. Is this acidosis, alkalosis, or normal? It's alkalotic, so write alkalosis beneath the HCO3 value of 34. Refer back to the baby's last name. Remember that the father of the baby has the same last name as the baby, which is acidosis. Do we have acidosis under CO2 or HCO3? It's under CO2, so the baby's middle name is respiratory. His full name is compensated respiratory acidosis. You see, a compensated condition is interpreted the same way as uncompensated. If the pH is normal, but either the CO2 or HCO3 is abnormal, just look at which side of 7.40 the pH lies. Below 7.40 is the acidotic side, and above 7.40 is the alkalotic side. In the next example, the pH is 7.43. Is this normal? Yes, it is. So the baby's first name is compensated. 7.43 is in the normal range, so determine which end of the range it's on. Is it closer to the acidotic side or the alkalotic side? Right, it's above 7.40 and closer to the alkalotic side, so the baby's last name is alkalosis, unless both CO2 and HCO3 are normal, which we'll discuss in a few moments. So the baby's first name is compensated and the last name is alkalosis. Now let's identify the baby's father and choose the middle name. The CO2 is 30. Is this acidotic, alkalotic, or normal? Correct, it's alkalotic, so write alkalosis beneath the CO2 value of 30. The HCO3 is 20. Is this acidotic, alkalotic, or normal? It's acidotic, so write acidosis beneath the HCO3 value of 20. Refer back to the baby's last name, which is alkalosis. The father of the baby has the same last name. Where do we find alkalosis? Under CO2 or HCO3? Yes, it's under CO2, which is respiratory. The baby's middle name is respiratory, and the baby's full name is compensated respiratory alkalosis. In the next set of values, the pH is 7.41. Is this normal? Yes, so the first name is compensated. 7.41 is normal, but is it closer to the acidotic side or the alkalotic side? It's closer to the alkalotic side, so put alkalosis for the last name. Now look at the CO2, which is 39. Is this acidotic, alkalotic, or normal? It's normal, so write normal beneath the CO2 value of 39. Next, look at the HCO3, which is 25. Is this acidotic, alkalotic, or normal? Right, this is normal, so write normal beneath the HCO3 value of 25. Now let's identify the baby's father. We have an interesting situation. We call the baby's last name alkalosis because the pH was above 7.40, but still in the normal range. However, both the CO2 and HCO3 are normal. Remember, the same rule applies. The baby and the father must have the same name. If both the CO2 and HCO3 are normal, then the baby must have a last name of normal. Refer back to the pH. It was 7.41, which is within the normal range of 7.35 to 7.45. Instead of a compensated alkalosis, this baby ABG is actually a normal ABG. The key to determining the difference between a compensated ABG and a normal ABG lies in whether either the CO2 or HCO3 are abnormal. If both are normal and the pH is normal, you have a normal ABG. Just remember, the baby's last name must always be the same as the father's. See how far you've come, all these different values, but you can interpret all of them by remembering the basic rules of naming the baby. Now let's try one more that's just a little different. The pH is 7.12. Is this normal? No, so the first name is uncompensated. Is 7.12 acidotic or alkalotic? It's acidotic. So the baby's first name is uncompensated and the last name is acidosis. Now let's find his middle name. The CO2 is 58. Is this normal, acidotic, or alkalotic? Right, it's acidotic. Write acidosis below the CO2 value of 58. Now look at the HCO3, which is 16. Is this normal, acidotic, or alkalotic? Correct, it's acidotic also. So write acidosis beneath the HCO3 value of 16. Remember, the baby's last name is always the same as the father's. The baby's last name is acidosis. Now look at the CO2 and HCO3. Which one is named acidosis? Both of them are. Both CO2 and HCO3 have the same name as the baby's last name. That means both of them are the baby's father. So the baby's middle name is respiratory and metabolic. So his full name is uncompensated respiratory and metabolic acidosis. This is referred to as a mixed acid-base disturbance. Now, as you'll recall, we talked earlier about PO2 and O2 sat. These are the other two components that make up the ABG interpretation. Although they are not utilized in determining an acidotic or alkalotic state, they are instrumental in assessing the patient's condition, particularly his or her respiratory status. Now let's tie the ABG analysis to possible causes and treatment modalities. You'll recall that the key factor in determining respiratory acidosis was a high CO2. This high CO2 results from the lungs retaining carbon dioxide rather than blowing it off due to inadequate ventilation. Poor respiratory function results from pneumonia, chronic obstructive pulmonary disease or COPD, and depressed respirations because of anesthesia or high-dose narcotics. Actually, any factor that causes a decrease in rate or depth of respiration below normal can lead to respiratory acidosis. Treatment is aimed at reversing this process. If your patient is sleepy from narcotics or the after effects of anesthesia, you need to closely monitor his respirations. If the respiratory rate is below 12 breaths per minute, try to arouse the patient and encourage him to breathe deeply and more often. If the respirations remain severely depressed, the patient may need to be placed on oxygen or even in extreme cases a ventilator. If respirations are less than 12 breaths per minute, narcotic analgesics should not be given. In extreme cases of acidosis, sodium bicarbonate may be ordered intravenously. The body's own compensation for respiratory acidosis is decreased excretion of bicarbonate by the kidneys. But as mentioned earlier, this process does not begin for 24 hours. If a low PO2 or O2 sat is also present, the patient should be placed on oxygen therapy. The main factor associated with respiratory alkalosis is a CO2 level below normal. Respiratory alkalosis can be caused by hyperventilation resulting from increased anxiety, pain, fever, chills, or sepsis. Treatment is aimed at increasing the amount of CO2 retained by the body. The classic first-line treatment is having the patient breathe into a paper bag. This technique enables them to rebreathe the CO2-enriched air, which was just exhaled. This treatment can be achieved in the hospital by the use of a rebreather mask. Sedation may be required if the patient is extremely anxious to slow the rate and depth of respirations. The body compensates for respiratory alkalosis by allowing the kidneys to excrete more bicarb. But remember, this process does not begin for 24 hours. Metabolic acidosis is associated with a decreased level of HCO3. The most common causes for this include diabetes, shock, and renal failure. Treatment is always aimed at correcting the underlying cause. Nursing actions may include checking the blood sugar and administering insulin as ordered for the diabetic patient. For the patient with renal failure, monitor fluid and electrolytes closely, paying special attention to the potassium, which often is high, and the sodium, which often is low. The body compensates for metabolic acidosis by hyperventilation, which will start almost immediately. Finally, metabolic alkalosis, which is associated with a high HCO3. This condition is caused primarily by volume depletion, hypokalemia, sodium bicarb overdose, corticosteroid therapy, prolonged vomiting, excessive nasogastric tube output, and diuretic therapy. Again, the main treatment would be to correct the underlying cause. Treatment modalities include monitoring fluid and electrolytes, administering IV fluids to correct volume depletion, potassium to correct the hypokalemia, and antiemetics to stop the vomiting as ordered. Be aware that it may also be necessary to alter or discontinue diuretic therapy. The body compensates for metabolic alkalosis by retaining CO2. This is accomplished by decreasing the rate and depth of respiration. You have now mastered the basics of acid-base balance, ABG interpretation, and treatment modalities. So here is a parting thought.
There's no need to flee. Now you have the key. Just remember the family tree of an ABG.